Production funding for Behind the Headlines is made possible in part by the WKNO Production Fund, the WKNO Endowment Fund, and by viewers like you. Thank you.
The state of vaccines and COVID spread in Shelby County tonight on Behind the Headlines. I'm Eric Barnes with the Daily Memphian. Thanks for joining us as we continue to do the show remotely. Tonight, I am pleased to be joined by Dr. Stephen Threlkeld, Medical Director for Infectious Diseases at Baptist Memorial Healthcare. Dr. Threlkeld, thanks for being here.
You bet, Eric. Nice to see you.
Along with Bill Dries, reporter with the Daily Memphian. So, Dr. Threlkeld, we're at this point where vaccines are starting to get in people's arms, and that is a great thing. And it creates a lot of hope for people and a lot of relief for people. But the rollout has been very uneven and very difficult in a way that has really increased a lot of people's anxiety, right? I mean, just the anxiety of where do I go? When do I get it? Am I in the right category? Rumors on the internet, just so much anxiety and frustration about it. What can you say, if anything, to allay some or all of that anxiety?
Well, it is one of these weird kind of dichotomy moments for us. It is arguably one of the best medical advancements of a lifetime to have these vaccines, these incredibly effective vaccines and safe vaccines available to us so fast. But the old saying in immunology is vaccines don't save lives, vaccinations save lives. And so we have to have people have confidence in this vaccine. It is an incredibly effective maneuver. But we also need to have people have confidence in getting it out there. We have to get it out to as many people as we can quickly and evenly through our population. There are over 350,000 people who've died of this. People have lost their businesses. Elderly folks have been shut in for months. Healthcare workers are strained and working overtime for months. So, it's a hard process, but none of those people are interested in that. We need to get this done. We need to work smarter and harder to accomplish it. And a big part of that is communication. We have to know where the bottlenecks are so that we can attack them. And I think one of the most frustrating things to people so far is that we haven't even understood why it's not faster. I think once you do that, once people are able to frame a situation so that folks can understand it, it's a little bit easier to accept the situation. It's a great thing that Shelby County has really picked up speed and really gotten rid of all of their vaccines, put it into people's arms. But it's also a terrible thing that we've run out of vaccine and don't really know when we're getting it again from the state. This sort of thing really shouldn't be happening. Somewhere along the line, there are some people that can arguably work smarter or harder and at least let everybody know what's going on and hopefully fix it.
You mentioned the state. I mean, do you hear this from other cities, from other hospital systems around the state, or we often think that maybe we're getting mistreated over here in the corner of the state. Is it something about Shelby County, or is it a statewide problem?
I think it certainly is a statewide problem. It's a national problem. So I'm not aware of any situation where people in other cities are flush with vaccine and we don't have enough. But Tennessee is in the top 3 or 4 states so far in distribution of vaccine, which is a great thing. I mean, that's something to be proud of. But the problem is the number 1 state has only given about 50% of its vaccines. And we're not grading on a curve here. I mean, we can all fail this test. And so we need to work very hard to get those numbers up for everybody, including the leaders, which thankfully we are in right now in Tennessee.
Well, before I go to Bill, one more on that question. There's so many things we'll try to get through, of course, today, but that 50%, and the New York Times has there are many of them out there, but actually it's Bloomberg has a really nice tracker that you can go by state, how many doses have been delivered to that state, how many have been distributed, and how many have been, shots have been taken. They assimilate information from various state and local health departments. We are at right around 50%. I think I looked this morning. So that of our doses in Tennessee have been administered, given to people. Is that 50%? In some states, we're about number 5 or 6 on that list. The highest are probably in the 60%. When I looked at that 50%, I wondered, is that the state holding back, give or take 50% of the available vaccine for that second dose? So when we look at those trackers, help us understand you said 50% isn't good. What would it be? 100% is perfect, or is it always going to be a little under 100% because you're holding back for that second dose?
Yeah, it's a great question, and I'm not sure that I actually have the answer. And that's part of the communication that we need to have. The
Fair.
fact
Yeah.
that you and I neither know the answer to that question is in and of itself a significant problem. So yes, there could be some held back. And at first, Tennessee actually had sort of an emergency supply that we held back, which I think is a very, very poor plan. But we've kind of taken care of that and really released it all. We hope more vaccine is coming. I mean, I'm about to go get my second vaccine right after this program, but we need everybody to have that chance and to get it taken care of. But yeah, I think the very fact that we're not certain about that, certainly the CDC has recommended that we give out as much of the first vaccine as we can, but we also know that the data are behind 2 shots, not 1 shot. And when we start going into delaying that second shot, we're just getting into a territory where we don't really know what the numbers are in that situation.
Let me bring in Bill Dries.
And it's easy to focus on the vaccine and maybe lose sight of, for at least a little while, the fact that we're in a holiday surge as we speak. So has the vaccine, without any fault being attributed to it, but has the vaccine kind of maybe made that problem worse?
I mean, that's a huge point, and I think a very good one. We've not done well in anywhere in this country at doing those things to prevent cases of infection. I've said for a long time, we're in a game of chicken. The virus is coming at us faster and faster and faster. More and more people are dying right now. Just as we're hoping to swerve off into a lane of safety provided by these vaccines, we don't need to be messing around giving this vaccine as much to do. We still need to be taking care of social distancing, doing those things to prevent cases, because particularly at the pace we're seeing now, by the time people get vaccinated to the point of herd immunity, we're going to lose, a lot of citizens to this virus. We're seeing a lot of deaths. They're increasing around the country, and we cannot ignore the second major issue that we have to face, just because help is indeed right beyond our outstretched hands on the near horizon. But we can't lose sight of that second point. If we do, we will lose a lot of people unnecessarily. And it's getting increasingly frustrating for those of us in healthcare to watch people die when we're so close. This is the beginning of the end of the process. But between here and the end of the end are a lot of deaths if we don't do the things that we need to do individually and collectively.
I'm probably not phrasing this technically correct, but is the virus deadlier now than it was at the beginning of the pandemic?
Well, it's a more interesting question than you might think. It's deadlier because more and more people are getting it, not per patient. I mean, certainly we do better at treating it. The virus, with all the worry of mutations that are making it more infectious and spreading to people, there's no evidence that those mutations are making it any more intrinsically virulent, defined as being more able to make people sick. But when you start having 3,000 cases a day, 3,000 deaths a day in the country, it's because there are so many people getting it. So it being more infectious will all by itself have a lot more people die. There's a difference in mortality rate and mortality. If the mortality rate even goes down by half, but 4 times as many people are getting the virus, guess what? Twice as many people die, despite that improved rate of death in individual patients that might be getting it.
Mm-hmm. When we did our first programs on this 9 or 10 months ago, there was so much discussion about testing. And there were even some scenarios that we talked about where, testing is going to be a regular part of life, a regular part of returning to work. Is that off the table now?
No, I mean, it's important to do. We just haven't done it. I mean, nowhere that I'm aware of have people been able to accomplish that. And there are a lot of reasons. I mean, but it's not in here because there's not enough testing available. We've been very blessed with available tests here. But I think at some point we have to, we clearly have limited resources of attention to this, if not money and other resources. We have to make a very big push to this vaccine, because the vaccine is the end game. It's the finish and the fix to this problem. Testing, while very important, I've said for a long time now, when people look back at this 50 years later, we will be criticized because we didn't test enough. We didn't test enough symptomatic people, and we didn't test enough asymptomatic people. But at some point, to sort of try to rebuild a structure to do more testing right now, I have likened it before to going out and trying to get raw materials to build a storm shelter when the tornado is now tearing through your neighborhood. We need to dive into the bathtub and put a mattress over our head. And that's in the form of these vaccines, which are highly effective. But no, we don't need to forget testing. We need to continue to test people. But the simple reality is the testing is down, despite the cases and mortalities being up. We have been unable to generate systems to accomplish that locally, regionally, nationally, everywhere.
Because the testing, and we'll go back to Eric after this, because the testing also at this point serves a critical function of allowing you to know who needs to isolate, who needs to be quarantined.
I mean, the solution to this thing for months now has been testing, diagnosing, quarantine, contact tracing. That's what we always should have done. The simple reality is that we haven't done that well at all, despite a lot of efforts from a lot of people. But now we have sprinkled into this has been the vaccine, which of course is the ultimate cure for this situation. So yeah, but it's still very important to do the testing. We don't need people while we're waiting maybe months to vaccinate locally and nationally. We don't need people walking around giving this vaccine to parents and grandparents who then might die of it. That's a tragic mistake to make, and we cannot forget the second job that we have, which really was the first job before distribution of the vaccine.
And I would rarely correct an expert who knows a whole lot more about this. I think you said you don't want people carrying around the vaccine to their family and friends.
Oh, sorry, yeah.
And I say that only, and not to be a know-it-all, but because let's use that as a segue. What sort of resistance or wariness have you seen to the vaccine? I mean, and that wariness is in some cases maybe expected, in some cases I find very surprising. I mean, so maybe we walk through. There are some stories of a lot of healthcare workers, and there have been surveys of healthcare workers. Stories in the LA Times had a really great story, anecdotal, but big percentages of hospital staff at various hospitals throughout California not wanting to. I mean, 40 and 50% of people saying, no, I'm not going to take the vaccine. Where does that come from, and have you seen that in Memphis?
Yeah, and thank you very much for correcting that misstatement. Yeah, it's very frustrating to those of us, in healthcare and infectious disease particularly, because this is a statistical no-brainer. And there's several ways that you can explain this to people. The biggest concerns are that it's too fast, and worried about long-term side effects. Those are the two general large groups of concerns. And the simple reality is that RNA vaccines have been in the works since before the turn of the century here. 2010, Moderna was formed. It's been doing nothing but trying to make an RNA vaccine for 10 years. And so it's not that new. There are RNA vaccines to rabies, to flu, to other things. They've just not been successful enough because we've now got the white hot intensity of every major pharmaceutical company in the world working on it. We're able to make it get into people and be more effective. So I think it's not a fair criticism in that regard. In terms of long-term side effects, vaccines don't really give long-term side effects that show up 6 months later. Now, sure, there are some side effects that come right away and might last. But when you look at this vaccine, we've given it now to, of course, into the millions of people once we're giving it. But even in the trials, tens of thousands of people got the vaccine. No one died. There were a few allergic reactions. They all did fine. But yet, while we're sitting here making this program, between 50 and 100 people in the country are going to die of coronavirus. I don't know that we need to say anything else after that. But certainly, when you look at the effectiveness and the safety, it is a statistical no-brainer.
And have you seen any resistance among healthcare workers? I'm not asking you to name names or institutions, but have you experienced that?
Of course. No, there's no question. I mean, we have an occasional healthcare worker that will, in fact, try to convince somebody else not to get it. But I think most of the people, when you actually sit down one-on-one and talk about it, and I do it all day long, most people can understand that the numbers, the decision is not whether or not to take a vaccine. The decision is whether to take a vaccine or to get coronavirus, which 70% of the people, kind of by the definition of what we think herd immunity is, are going to get the infection if they don't get the vaccine. And to suggest that those two are equal in risk, I think is really very, very unsupported by the data. So, but yes, we certainly see people say it. Most people, if I talk to them for 5 minutes and point out these numbers, will actually say, wow, hadn't thought of it that way. And we don't need to get our information from Facebook or from our brother-in-law that might be very articulate, charming, and nice, but may not know anything about what we're talking about.
One thing, I mean, we are what 9, 10 months into this, and some of this parts of this conversation are giving me, flashbacks and PTSD to conversations we had with you and other infectious disease experts about what we need to do, and it is kind of mind-boggling that we are still here in 2021. But in that time frame, a lot of people, and we'll just stay in Shelby County, many people in Shelby County have gotten the virus. Some have gotten very sick. Obviously, some have died. Some have not even known that they had it, probably, right? I mean, it's just such a strange virus that way. If you've had it and you know you've had it, do you still need to get a vaccine?
Yeah, it's a great question. That's the other main raft of questions that I get. And the CDC has come out with a fairly nice position paper and update to their recommendations on their site, and I recommend people look at them. So yes, if you've had the infection, we don't know how long that immunity is going to last. Now, we don't, in fairness, know how long the vaccine immunity is going to last either, but that's baked into the vaccine trials. We'll continue to watch these people who were vaccinated months ago now, over 2 or 3 years, to see if they start getting infected after a year or 18 months. And that'll clue us in to the fact that we might need to get it as well. But absolutely, it's a very critical thing, I think.
One more question I'll go to Bill about vaccines right now there's been a lot of focus on the drive-through sites that at the Shelby County Health Department opened. There's a lot of confusion who was allowed in there, and who could come in 75 and above. It was a tremendous amount of confusion that they then tried to clarify. And they are up against, as they will say, and as you have just said, upstream, they don't know how much vaccine they're getting. They don't have clear guidance. I mean, it is a very difficult situation, to say the least. When we get this right, a week, a month, let's call it a month from now, where will the bulk of people get their vaccines? Will it still be through the Shelby County Health Department or at a drive-through site? Will it be at a pharmacy? Will it be at their local doctor? Will it be at one of the hospitals in town? Or do we even know?
Yeah, I think that's a game, unfortunately, of 3 or 4 dimensional chess right now that we're playing. We don't know which other vaccines are going to come out and be approved in some of those months, which may make delivery to pharmacies and other places a lot easier. It may make it easier for that to happen. Right now, I think for the just immediate or foreseeable future, we're sort of stuck because of the logistics of this thing with hospitals and with health departments in larger centers to distribute this thing. And I hope certainly that it becomes much easier and we're able to do those things, because let's face it, in the same way that FedEx was able to distribute the vaccine very, very quickly to people, if we were able to get it safely and effectively out to private enterprises and pharmacies and so forth. And pharmacies, of course, are already helping with distributing it to long-term care facilities and nursing homes. So I think that'll be very important. And let me just back up to the last question too and say one thing, is I didn't actually fully answer it. Yes, people who've been vaccinated or who've had the infection do need to get the vaccine. And one other question that comes up almost daily to me now, and it's a sidelight to your question: what happens if you get infected after you get the first vaccine? And so the reality is that you can wait up to 90 days to get that second one, because the infection itself is felt to reliably give us immunity out to 90 days. After that, they recommend that we go ahead with those vaccines. And so it gets a bit complicated. It's the kind of thing that you may have to check with your doctor about whether you've been infected and the exact timing that you would get those vaccines.
All right, let's go to Bill.
And I believe what I've seen in the guidelines for the city sites that they're operating is that for people who are concerned about any side effects, that they actually watch someone who gets the first shot for a period of 15, 20 minutes to make sure that there's not an allergic reaction.
Exactly right. I mean, the standard has sort of become 15 minutes, and that's what we do at hospitals. That's what, and I've had some elderly relatives vaccinated. One at the drive-through site went very well, and they just have you sit there in the car while somebody is standing around in case you have a problem. And certainly some people are going to have allergic reactions, but again, let's point out the fact that no one has died of this vaccine. It's 350,000 plus to 0 is the mortality comparison of the vaccine versus the infection. So they have epinephrine pens for people who do have allergic reactions at all of these sites. So far, that really, I think, has gone very well.
Mm-hmm. I think that sometimes in dealing with situations like this, where there have been things like flu season, we're used to the experts having a consistent degree of certainty. And from the beginning in our discussions just on this program, not to mention the many other discussions about it on the air all over the place, you and other experts were very upfront with the fact that we're going to learn things during the process of this, and some of it might contradict what we believed earlier. It might change what we had believed earlier. And that's kind of part of the method of what you and the other experts, how you approach these problems, which is kind of different from the public policy, or I'll call it the political part of the equation, isn't it?
Very much so. Science and politics don't always mix very well. Poor Dr. Anthony Fauci has been in charge of sort of being a scientist and helping to run the actual progress of this, of fighting this infection, and then also having to give messages out politically. And one can only feel sorry for that situation. Because in politics, the CDC has 330 million patients in their waiting room in their office at one time. I have one. And so it can be very different in how you kind of deal with those things. But science works very differently. Science makes projections, makes guesses, makes hypotheses, then it gets tested. We find out if they're right or wrong. Other people have to replicate it. And I think it goes back to the very beginning of this pandemic. We thought we were just going to science it to death, and this wasn't going to be a problem in our country. We were going to take care of it. We found out very quickly otherwise. New York got their nose bloodied very quickly, and so did the rest of us. And so then there became this sort of depression about it all, and that science wasn't going to be able to do it. And then sort of kicked in the incremental advancement of facts and studies and tests. And that's really what's gotten us out of this, is that created the vaccines, is real science. But real science is wrong. Real science is wrong by definition and frequently. And we have to be able to realize, we have to have the humility to say, we were wrong about that, now we know this. But that's not a conspiracy, that's not misinformation, that's just what science is intrinsically.
Right. And as you said, the mix between those two, public health policy and public policy via elected bodies, appointed bodies, those two instincts are very different in terms of dealing with the public. I think sometimes when doctors are dealing with one another, because of your training, you know that we don't always know that when we're listening to it.
Yeah, I think that one of the most frustrating things to me is the accusations that doctors are part of a conspiracy theory. And not many people say that, but enough where you sort of look at it and say, are you kidding me? Doctors are not very organized or politically savvy. Arguably the most intelligent, in terms of just IQ, presidents we ever had was Richard Milhouse Nixon. And he came down in flames because he couldn't bring off a two-bit burglary at a hotel across town. This can't be done at the scale we're talking about. Doctors and other healthcare people, nurses, they're just trying to get it right. And we will be wrong on occasions and make mistakes, but hopefully, we'll do the best we can to correct those errors and get out the message that we were wrong and now we know better and we're trying to do the right thing.
All right. A final point before we go back to Eric. In talking about distribution of the vaccine and it becoming easier, would some of that be a function if we had vaccines that were single dose and didn't require the elaborate refrigeration that we've seen with the two most familiar vaccines out there now?
Absolutely, a very key point, and one that we hope it's a problem we hope to have, is to decide which vaccine to give. Johnson & Johnson, for example, is a one-shot vaccine. That would be something of a game changer because it's easy to store, it's easy to give. You don't have to have the bureaucracy of keeping up with who's had the vaccine, have them come back the next time. It removes entire layers of barriers to getting this done in that sense. And some of the ones that don't require such ultra cold storage allow us to get it out to more rural areas, places that really can't get the Pfizer vaccine just because of the logistics and the practicality. So yes, if we get vaccines that are approved that are one dose, it's going to be a very, very important extra weapon we have in this fight, to be sure.
One thing you going back to something you said earlier about holding back vaccine. Shelby County is out of vaccine, and as you said, that's a good thing in the sense that they're pushing it out and they're trying to distribute as quickly as possible. There was part of that confusion and anxiety, and that I talked about at the beginning, was this lack of clarity on what groups had been green lighted, and guidance from the state that, look, if someone's in line, go ahead and give it to them. Although messy, is that the right policy? I mean, because again, you're pushing the vaccine out. It will expire. More will come. I mean, should they be erring on the side of giving people shots versus, no, this is the hard and fast category. You're not in that category. We can't help you.
Well, there are about 8 layers to that question. And really,
You have a minute and a half to sort it out.
So yes, I think the CDC, and I would agree, it has said, try to get all the vaccine you can. That presupposes that there's going to be more vaccine coming, right? And so the more that is a problem, the more people lose confidence in that sort of thing. And so I think the state was actually holding back an emergency supply. And I was critical of that. I said, look, we're in the biggest rainstorm in 102 years, and we're standing in the wettest spot on earth. We do not need to be holding back umbrellas or any other such tools to fix this. But at the same time, you have to have that supply from upstairs, or we end up with a one shot and no second one coming. I think it's going to come. I think that we'll have the production. But you're right. I think we should err on the side of giving it to people when we can. Although the British idea of putting it off 3 months, we don't know what we're doing there. I think the data are just not very strong to do that in a planned sense. That's a different matter.
One more question. One of the huge stresses we've talked about for 9-10 months now is not just the deaths, not just the illnesses, not all that. It is also the stress on the healthcare system. What are you seeing right now in terms of the maxing out of rooms and availability? But those data are on our site and they're in places. And with just 30 seconds left, what are you seeing in terms of the stress level, the emotional and physical and sort of toll on healthcare workers like yourself and the people around you? That has been a huge concern, that they are burning out.
Yeah, I think it's something that people can't really understand unless you're doing it 17 hours a day to accomplish this. There are family members dropping off elderly relatives, not knowing if they will ever see them again. And we have nurses spending hours in rooms connecting patients with cell phones and FaceTime, knowing that they will never see their family member again in person. They can't come visit and they're going to die. And if you think that doesn't take a piece out of those nurses every time that happens, you're wrong. It is a very big problem, and they're having to do it for months on end. And I feel for the doctors. We walk in and do the interviews and stay there for 15 minutes and talk. The nurses really though take the brunt of that, and it's very difficult to watch, even let alone for them to do.
All right. Well, on that difficult note, thank you, Dr. Thorcott, for what you're doing. Thanks for being here. But that is all the time we have this week. Remember, you can get past episodes of the show on the WKNO website at WKNO.org, or you can download the full podcast of the show from the Daily Memphian site, iTunes, Spotify, or wherever you get your podcasts. Thanks, and we will see you next week.